Welcome to a brief introduction to mechanical ventilation. This is Chapter 7.1, Ventilating COPDs, Pathophysiology. In the asthma section, you may have noticed we only talked about hypercapnia and not hypoxemia. Asthmatics can be hypoxemic if mucus plugging causes shunting, but really the main point I wanted to get at was to focus on hyperinflation and hypercarbia, which are the predominant problems in patients with severe asthma attacks. COPD, on the other hand, is a chronic disease and usually presents with intermittent acute exacerbations. Patients with COPD who require mechanical ventilation will frequently present with hypoxemia, chronic hypercarbia, and a new acute respiratory acidosis. COPD causes VQ mismatch from destruction of the alveoli and small airway disease. When somebody gets an acute exacerbation, this makes the VQ mismatch that much worse. As well, the respiratory muscles increase their oxygen consumption and can top off at close to 40% of total oxygen delivery, which further decreases the venous oxygen saturation. The total shunt fraction doesn't necessarily increase significantly, so usually the hypoxemia can be corrected with just a little bit of supplemental oxygen. Hypercapnia is probably the more significant problem, however, because it is usually much harder to fix. Patients with an exacerbation will have an ineffective breathing pattern of rapid and shallow breathing, which, when combined with the fixed anatomical dead space, leads to a reduction in total alveolar ventilation. Recall that this is a result of the increased fraction of tidal volume to dead space ventilation. At the same time, airway resistance also increases from bronchial inflammation and mucus, which causes a prolongation of the expiratory time. As we have recently discussed, this problem of prolonged expiratory time causes dynamic hyperinflation and an increase in the intrinsic PEEP. At a steady state, patients may already have a degree of intrinsic PEEP of a few centimeters of water, but with an acute exacerbation, this goes up. This increased intrinsic PEEP leads to increased respiratory effort and eventual respiratory muscle fatigue. Once respiratory muscle failure occurs, hypercarbia is inevitable.